everyone, thank you for joining us because we're excited to spend the next hour discussing, as Jenny said, two of the most complex populations that we see in case management, individuals living with traumatic brain injuries and spinal cord injuries. And really between Nolan and myself, I call it a privilege. We've had many years of this privilege working with catastrophic injury survivors and their families. And, it's never just about the medicine, right? There's so many people around the injured, what we call injured worker in our space, that also are affected. So we're hoping to share the science and maybe some real world practical lessons that we've learned and we can pass along to you all.
Absolutely.
A little bit about ourselves. I'm Patricia Carothers. I am the owner of MyNetRN. It's a national case management company. And we do specialize in catastrophic cases, but I'm also so passionate about education and bringing real world experiences to viewers like yourself. In addition, we have a podcast. We have a podcast where we talk about all things work comp. So please be sure and stay in touch with us. Our contact information will be at the end of the presentation, but we're happy to be here.
Yeah, absolutely. And thank you, Patricia. I'm Nolan Carothers. I am a field case manager for MyNetRN. I'm catastrophically trained field case manager. So definitely working hands-on with these type of injuries with TBIs and SCIs pretty much daily. I'd say I have quite a few in my queue right now. And I have a background in neuroscience, so as it ties into traumatic brain injury and spinal cord injury, kind of really like to apply that, science-backed knowledge, that clinical knowledge to real-world care management practices. I'm really passionate about doing that. So,
thanks, Nolan. It comes through. Your passion comes through, and your clients and your injured workers really appreciate it. So, I should say there are no disclosures to review today, but Nolan will take us through the learning objectives.
Absolutely, yeah. So learning objectives, really just three kind of keywords we want to focus on here. There's a placard dedicated to each one. First being differentiate, next being identify, and the third being apply. So just keep these in mind as we go throughout the presentation. When we're talking differentiating, we want to speak to differentiating roles and goals. We want to make sure that we're who's supposed to be taking care of what with care coordination across the workers' comp field and also internal case managers, as well as the private concierge care model as well. Then we're talking identify. We're looking at where can we intervene, what resources can we pull in to support the recovery, the rehabilitation process. So identifying where a case manager can actually have an impact on the file. Definitely good to keep in mind as we go through these different case studies.
Yes.
And then lastly, apply. We want to be able to apply those interventions and apply effective communication between all parties so we can all collaborate to having the best possible outcome for the injured worker as they transition between different levels of care and different care coordinators. So just differentiate, identify, and apply our learning objectives today.
And you can't see it on the slide, but it should have like hats in the background because all of these objectives, we wear many hats.
We wear many hats.
All right. Thanks, Noel.
So let's talk a little bit about why catastrophic injuries matter. When you have a catastrophic injury, like any injury, it happens in a moment. It's a snap of the fingers. But when it comes to catastrophic injuries, the recovery is going to take years. It's not like a lumbar strain where they may be back to work very quickly in the work comp space. It's going to be a long-term rehabilitation program that's going to need to be built around what they need from a clinical perspective.
Yes.
So we have here just an outline of the injury trajectory. So you have the time of the injury. That's when someone was hurt. EMS arrives. They're transported, usually via ambulance, to the hospital in these type of cases. And then a lot of times in these type of cases, they're not going to be discharged to home. It's going to be a rehabilitation facility. So selecting and identifying what the right level of rehabilitation is really key to make sure that we're getting the best possible functional outcomes following the discharge from the hospital. And then after they leave the rehabilitation facility, they will be going back to their home. So making sure that their home is set up properly for them, making sure that their family members know exactly what's going on and what they will need for their care. Is another case manager role. So we're able to educate the family members, educate caregivers, and make sure that the transition from rehab to home is as smooth as we can be. And finally, the overall final goal is to get them back into the community, return them to the highest level of function that we can. And so, while the accident lasts seconds, the recovery is going to last years, and that's what we manage.
And we really are the constant, I would say, as case managers across all of these stages.
Oh, absolutely.
And keep that plan going. Thanks.
In an ideal world.
In an ideal world. I like this slide, and it's big. Numbers are big, and I just think it's important to be aware that there is a big financial impact from just one catastrophic claim. You can read the placards from side to side, but just so that you know, catastrophic claims are rare, but they do drive a disproportionate share of costs. So the 181 billion, that's the total U.S. work injury costs from 2024, including wages, lost productivity, medical, administrative costs, et cetera. And out of those type of injuries, less than 0.5% are what we consider large catastrophic claims, those of 1 million or more. So they are a rarity, right? They're individually uncommon, as you can see in the next placard, 1 in 1295. They're individually uncommon, but collectively they're very expensive. And carriers will absolutely see these types of claims, carriers being the insurance, the payer. When you look specifically at a traumatic brain injury, a TBI cost, that can average about 136,000. When you compare that to 51,000 for just your average claim. So almost 3 times as much for a traumatic brain injury. And the last placard, this was from the Christopher and Dana Reeve Foundation, the spinal cord injury lifetime direct care for a youthful individual, 25 years old, that suffers a spinal cord injury can be as much as 5 million. And carriers have to manage these claims from beginning to end. We're going to cover that on the next slide. But early coordination and all of the things that we do as case managers through discharge planning, equipment readiness, et cetera. It's not just good care, it's also financial stewardship when you look at this slide.
Because you got to consider who's going to be paying for the care.
And it's costly. We'll talk about work comp first to show that catastrophic claims are managed on a separate track from your routine claims. Not that a claim is ever routine, but walking through the stages left to right on your slide, early identification, severity is flagged at the first report of injury. The carrier will use a diagnosis, the body part, other predictive triggers, so that right resources can be attached early on.
Right away.
And it flows into another queue, specialized handling. It's not just the regular general queue, it's a complex claim unit that's used to handling what we call CAT claims, to use the slang. Senior adjusters, they usually have a dedicated case manager. And then, like us. And it's not always nurses. There's also non-nurses who are catastrophically trained to manage claims very well.
Thank you.
The large lifetime reserves are set. Life care planners are used to project the decades ahead of us, what's going to be needed medically and attendant-wise, equipment needs, et cetera. But all along, we're looking at that cost containment again. We know how that financial impact can grow so large. So specialty networks, specialized vendors that we use for equipment, they usually have negotiated rates with the carriers. And ultimately, we're going towards resolution. These type of high profile catastrophic claims will close through either a structured settlement with the set-asides or maybe stay open for lifetime active management. It just depends. But the takeaway here is you, as the case manager, is that coordinating layer across all 5 stages. And that's where our work sits.
And even beyond, if it's going to be a lifetime active management claim.
Yeah.
So even beyond resolution, this last step here, you may have case management activity on the file.
Spot on. Spot on.
And so, as Patricia just mentioned, we have early identification and special handling, and they will bring in maybe a specialized case manager for catastrophic claims. And this here is just kind of outlining why early intervention really matters. We always say, like, wouldn't it be great if we were just there every time from the get-go?
Oh, we say that. Yeah. We say that all the time.
It doesn't always happen that way. They don't always, bring in a catastrophic case manager right away. But when you do have a case manager on the file early definitely can deliver some really good outcomes. Specifically, the three listed here. The first one being improved clinical outcomes, making sure that we're getting the right care at the right time, can accelerate recovery timelines, making sure that we're placed at the appropriate level of care
Right,
when you're
right.
going to a rehabilitation facility. That can also reduce total costs, making sure that the clinical outcomes are improved. So that way we're avoiding readmissions, which can be very costly.
Yes.
When you have readmissions, you're going to have duplication of all your services, redoing all of the imaging, redoing all of the consultations. So you want to avoid those
Ka-ching,
things.
ka-ching,
Exactly.
ka-ching.
Those
Yeah.
those can definitely run up the costs very rapidly. And then finally, like with the case manager on, in terms of the reducing the costs, you can catch things early. You can catch, maybe the skin integrity is being reduced in the case of an SCI.
Mm-hmm.
It's something that you can catch early on, and it can reduce late stage costly interventions. And then finally, with a case manager, you're going to have a high return to work. So when we're talking work comp, our goal is always to return to work. We always want to get the injured worker back to work as quickly as we can and as safely as we can. So having a case manager on the file early can help promote aligning rehabilitation goals with what they need in terms of their ability to return to a functional work capacity. Are they going to be going to the same line of work, different line of work? These are all things that a case manager will be able to coordinate. And then on the left side here, we just have two numbers to kind of keep in mind, which we'll return to later as well. But the 32% of savings, lifetime medical cost savings, with the involvement of a case manager, and also a 75% increase in return to work rate with the addition of a case manager. So
and we'll back up
really
these numbers a little bit later.
Yeah,
we will. So, but thank you for sharing that. Early intervention does indeed matter, and we decided to create our presentation around two very specific case studies, and just for purposes of making the conversation fluid. Our first injured worker is Roger, and I'd like to introduce him. Very nice man, 42 years old. He was a construction foreman. He's married happily, two kids. And as most of our catastrophic injured workers, and again, in our world, it's not patients, it's injured workers, he leaves for work thinking everything is normal. And unfortunately, he falls from a scaffolding and he suffers a severe traumatic brain injury. So for Roger, and Nolan will speak to this on the next slide, everything happens immediately, that primary injury. The coworkers that witness it, they're distraught and they're affected. The employer wants to make sure they're connecting all the dots and doing the paperwork correctly. Family's been contacted. They don't know if Roger will even survive. There's so much chaos and so much worry. The case manager will come in and join Roger and all of these other players on this catastrophic journey.
Yeah, exactly. Hopefully to help them along the way, best we can. So understand Roger, we need to kind of quickly, holistically give a 10,000-foot view of just TBI in general.
Thanks. Okay.
So TBIs in general, the deficits are going to not necessarily be visible. Like when someone breaks their arm or someone breaks their leg, it's very obvious. It's a very obvious orthopedic injury. They're going to, set it, stabilize them. And yeah, exactly. The treatment is very straightforward. With the TBI, the deficits are often going to be invisible and they're going to occur also over time. So in Roger's case, he's a construction foreman. So we're going to be kind of putting these all into place based on his return to work and his return to function. So with the first placard here, we have frontal lobe damage. This is something that can affect your judgment, your planning, high level core executive functions.
Okay.
So with Roger's case, this may be a safety risk for safety at home, his safety on job sites. That kind of damage can lead themselves to risks in that aspect. Next, we're going to have memory impairment. The first thing that you ask someone when you suspect a head injury is like, oh, like, do you know what day it is? Do you know where you are? So that's the short-term and working memory. Those are very commonly affected across head injuries, whether they be severe or mild. And it affects our ability to encode new information. We're able to actually retain new information. So in Roger's case, this may cause issues for medication adherence.
Yes, and it did. It did.
Potentially the care compliance. Is he doing the things that he needs to be doing for his recovery? Next is executive functioning deficits, kind of tied to frontal lobe damage, but in Roger's case, he's a construction foreman. He needs to plan out job sites. He needs to be able to do high level problem solving.
Yeah.
He needs to multitask. He needs a lot of different moving pieces in his job site. So this is kind of aspect may limit his independence and his ability to return to that same line of work. So that's when return to work planning comes in. Is he going to be doing a similar type of work? Is he going to return to the same employer? So definitely something to keep in mind with traumatic brain injury. And then finally, impulse control challenges. Oftentimes when you have severe TBI, they have a difficult time regulating their emotions. And this comes from more the family. They're going to say, oh, well, they're just really not acting like themselves.
Yes.
I noticed that they're more quickly to anger. They're getting frustrated very easily. And so with that, there's a risk with living independently. Maybe they'll have to have some kind of caregiver. And also there's a community safety aspect. We want to make sure that they're being as safe as they can in their community.
And I like this what do you call it, a 10,000-foot view, because it kind of will lend itself later in the presentation to how we manage across transitions. But if we think about Roger and the point of impact, the first 72 hours, if you could just walk us through kind of your assessment on why that critical first 72-hour window is so important.
The first 72. So when we're talking on the placards here on the far left, we have the primary injury. So this is EMS arrives on site. There may be contusions, bleeding, so kind of maybe skull fractures potentially,
and loss of consciousness.
Axonal injury, so you have like a shearing force in the brain specifically, and maybe bleeding in the brain also. And this all happens before EMS arrives, and you can't reverse this portion of the injury. This is what happened. Here's the injury. Let's get into the hospital. And then the first 72 hours is key for reducing the secondary injury. So that's the next kind of placard here, where we want to reduce as much as we can the impact of these inflammatory pathways, or you have issues with hypoxia, issues with blood pressure or cerebral blood flow problems. And so with that, they're really like critical risk that they're looking for the most in the ICU in the first 72 is the swelling and the intracranial pressure. So this can lead to rapid irreversible damage in the brain that we should be able to mitigate. It's not part of the primary injury, but we can do our best that we can to mitigate this secondary injury. And the way they do that in the ICU is via neuromonitoring. So they're going to be monitoring GCS trends. If they suspect a bleed or they have a bleed, they're going to be doing repeat CAT scans to monitor the progress of that. They'll be doing pupillary checks, monitoring blood pressure, and all of these can be good indicators for that intracranial pressure, making sure that we're keeping it at a nice stable level to the point where they can then be stepped down from the ICU.
I like to use the word mitigate. We're trying to mitigate any further damage from that primary injury. While this is all going on, this clinical perspective, case management walks alongside. In the first 72 hours of a critical injury, catastrophic case management is there as well. And thank you for walking us through that clinical piece. But while the ICU is stabilizing the injured worker medically, the catastrophic care manager is stabilizing the family. Okay. But let's talk about how you get started. We tell our staff, you've got to have your go bag. When that call comes in and you get a catastrophic case assignment, you got to have your bag at the door, because you don't have time to gather a set of clothes and extra water and snacks and all your documentation, your ROIs, everything you have to take with you out the door, your business cards, because you need to be at the hospital as quickly as you can to establish that presence, that introduction. Well, when you first get to the hospital, who do you try to make contact with first?
The very first person that I try to get in touch with is the nurse that's on the service.
Yeah.
So in Roger's case, making sure that is he alert and oriented to what's going on, is his family members present, and the nurse on service will have all that information. So that's typically my first stop.
I would agree. And also the internal, if there's a case manager internally, whether it's a nurse or a social worker, because we get there and they don't realize this is work comp. Yeah, they don't know. And so it's our job to establish the presence, why we're there. And if, like Nolan said, you get approval to meet with the family, that's what we're going to do, is we're going to explain to the family who we are in plain language, why we're there. They're so overwhelmed. They need to have one point of contact, a calm structure established from the get-go. They may have driven across the state because Roger may have been injured on a job site several hours from where he lives.
Okay.
They might need lodging.
Yeah,
They
place to
might
stay.
a place to stay.
Mhm.
They might need to know where the cafeteria is. So we're establishing that rapport and that early relationship. Um, Coordinating the stakeholders would be in work comp. There is the payer, there is the employer. Sometimes there is legal counsel. So all of these team players have to be part of the communication coordination. Um, Basically, you're there to establish the connection with the family and the injured worker first. Everyone else ripples out from that, and anticipate the next transition.
Absolutely. And then in Roger's case, in the first 72 hours he's in the ICU, it's more focused on medically stabilizing him. So as a case manager, we're looking ahead. We're looking at where are we going to be discharging to? What does he need for discharge in these very first 72 hours? So it's not reactive when that does come up. We've been proactively planning for it from the very minute that we arrive on.
It's like a 4D chess game. You're several moves ahead. You are thinking it because and we just wanted to pop in here this slide because when we talk about relationships with the internal staff, it's our job to make sure that we understand who owns what. This slide combines the internal and the external case manager, which could be a presentation in and of itself, I'm going to say. The internal case managers, they're so great. They have the strongest view of the acute setting. Has the doctor made his rounds? What time is he going to show up at bedside today? Can the family be there when he does show up? Have OT and PT signed off so that we're getting closer to discharge? We, as the external case managers, usually have the strongest view of the family and the community, I would say. What the home environment looks like. Has the DME been delivered by Amazon and sitting on the porch? We need to coordinate the outpatient providers and follow-up care. So neither of these roles exists in isolation. We have to be sure that the handoff is really, really clear because we're looking at those good outcomes, both clinically and financially, that we talked about before. So just clarify the role from the very beginning.
Absolutely. And this is a good way to bridge that gap and prevent gaps from happening.
Gaps do happen.
Gaps do happen. And, talking about bridging gaps and bridging communication pathways is another good role for your catastrophic case managers. So kind of the left and the right placards here mirror each other. We have the ICU and we have the rehabilitation facility. So in Roger's case, where he will be being discharged to. Yes. After he's been stabilized, everything's going okay medically. He no longer needs to be in the hospital, but we're going to move him into a rehabilitation facility. So in the ICU, we're looking at stabilizing, making sure that the intracranial pressure is staying stagnant and also the neuromonitoring is going well. Right. This is where all the clinical documentation is happening. We're doing labs, we're doing diagnostics, and all that information is to be compiled and then communicated to the rehabilitation facility. Mm-hmm. So when that way, the rehabilitation facility, they're not just getting, hey, we have a TBI coming in, do you have a bed kind of type situation. They have an understanding of, here's, Roger's cognitive functioning. Here's what he may need for support. His family is going to be in the area, so they'll be by to come and see him at the rehabilitation facility. So we want to make sure that the goals of rehab are aligned with his actual deficits that were determined in the clinical setting. And in the middle, we have the catastrophic case manager. We serve as a translator between those clinical findings, communicating them to their rehabilitation facility so they're able to turn those findings into a type of rehabilitation plan that's very tailored to Roger specifically. And when we're able to tailor plans very specifically and very well, it's going to lead to better functioning outcomes in the rehabilitation process.
I like that you use the word translator on this slide because everybody speaks a different language. ICU language is different from rehab language, different from what the family speaks. So as we move into the next slide on trauma center to rehab transition, again, make sure everybody is on the same page, hopefully speaking a similar language and getting Roger to the right environment. Fair. I think Robert's your other one that you have right now. These cards kind of zone in a little bit more on the story, starting that with placement isn't enough. If we simply move Roger to the next setting, but his clinical context doesn't travel with him, the people who are receiving him don't have the full picture.
Yeah, they don't know where to go to next.
So I just want to say ownership is the fix. Before every transition, before every handoff, have have a knowing of who owns the next step. And ultimately, in Roger's case, this really included the workers' compensation adjuster, because if the handoff is fuzzy, didn't she didn't know what she was authorizing. Why does he need this rehab? Why does he need this equipment? So you have to loop that conversation, loop them into that conversation as well.
And if you don't, I think that kind of speaks to the second, where it can cause delays in cares, and you can have missed equipment, and can that can lead to preventable readmissions when you have those kind of things happen. So
Yes, it puts you behind the eight ball
mhm.
instead of getting out in front of it. So who owns the next step? What's the next action? And ultimately, what's the next risk?
Yeah, so we don't know what we're dealing with risk wise. We don't know how to mitigate it and how to prevent it and how to address it when it does arise.
Thank you. I don't want to stay on the negative. I just wanted to give a little bit of a risk and then show a little bit of a fix. So we understand that communication is probably one of the biggest potential failures in catastrophic claims, and they're rarely purposeful. They're usually subtle in the beginning. Somebody assumed that somebody else was owning it. So the fix is to make communication very intentional, that there are on the right hand side, I like to focus on the green. Green means go. Warm handoffs. Okay. Have those direct discharge meetings with everybody involved, even if the family can be there. Share the care plans, define responsibilities. And I know for our 55 minutes here together, we can't walk through every detail, but just know that good communication is not just an event or a skill. It's actually a risk prevention process.
Absolutely.
Go green.
And with the, that risk prevention, one of the things that we wanted to give you guys today is a readmission prevention toolkit. So this is something that I just always kind of keep in the back of my mind when I'm working on discharge, in Roger's case, specifically from the hospital to the rehabilitation facility. So just kind of like a general mental checklist. So the first one being family education. We want to make sure that any of the caregivers, in Roger's case, his wife is maybe a caregiver when he is discharged home. So she needs to be educated before he's discharged anywhere, either to rehab or to home, on what's going on with Roger's situation, how she can best assist, and what she will need to know for the next steps. The next one is going to be DME readiness. Sometimes you need DME delivered to the hospital directly in order for maybe they're not able to ambulate on their own. They need some kind of assistive device, but they're not able to actually be discharged to the rehabilitation facility
without that
device. Mm-hmm. So determining where the DME needs to go and making sure that we're confirming that delivery. A lot of DME is going to be sent to the home. So making sure that it's delivered and also received when it gets there, so you're not losing things, in the mail. Next is medication review. We want to make sure that is Roger bringing his medications with him to the rehabilitation facility, or they're going to be sent to his pharmacy and maybe his wife will have to go pick them up? Is the rehabilitation facility going to be giving?
Or is it meds to beds in the hospital?
Mm-hmm. Yeah. So just clarifying and making sure that everyone's on the same page with where medications are coming from, who's prescribing them, and what he needs to be taking. It's definitely key to keep in mind. Next up, we have home assessment. So at this point, he's going to be discharged from hospital to rehabilitation. And then we are going to have an OT go up to his home and see, is there anything that we need to adjust or modify in his home to make it as safe as we can for his discharge eventually to home, because that is the goal. Next up, we have follow-up appointments. And again, it's not just like a piece of paper that they get during discharge. It says, hey, your follow-up in 10 days with your neurologist. We need to go out and confirm with the outpatient clinic for neurology that, hey, Roger's coming on this day, this time, and make sure all parties are aware of that. Because a lot of times he will be going to outpatient appointments from the rehabilitation facility. So the rehab staff also needs to know, hey, Roger has an appointment this day. We need to arrange some transportation, which is the last little bit of the placard here.
Good segue.
Thank you. And we want to make sure that the transportation is, arranged and tested. Maybe his wife wants to take him to appointments, but she doesn't have a vehicle that can accommodate it. Maybe he's not able to get into it because it's too low or too high. So making sure that the transportation fits what he needs is something that we have to check and not just assume.
I have two stories that came to mind while you were speaking. The one under DME readiness was your gentleman who was using his shower chair incorrectly.
Oh yes, he's using it. So
it was a transfer bench.
Tub transfer bench. And he called me and he said, "Hey, I can't fit the tub transfer bench into the tub." And I kind of walked him through it on the phone, and it turns out that he had not been educated properly before he was discharged to home, that the transfer bench is for transferring into the tub. He had the whole thing set up inside of the tub.
Side, yes,
Yeah.
it just wasn't.
So just, just things like that where you can't always just assume that they know how to use what they've been given to make things more accessible.
Thanks. Also, expect the unexpected. The follow-up appointment piece that you spoke to, I was actually sitting with the internal case manager in her office while she made the follow-up appointment with the neurologist. Then 10 days later, when I go to confirm the appointment, the office tells me, we don't have that appointment on the books. So you
That's the best.
just have to quick fix that.
Yeah.
Fix that. So I think oversight, case management oversight is really key on this slide.
Oh, yeah, absolutely. So like all of these things are happening all at once, and you're not going to just say, okay, family education, check. They're going to be things that you're actively revisiting. You're not just passively checking off the list. It's going to be something that you're going to return to continuously. So we are preventing those readmissions with this toolkit. That's kind of the goal. So
and we do use this. We do whether it's a binder that everybody has access to, and everybody meaning the team, the family, having the list of the transportation company, the DME company, the med list. It's very helpful for the family. And we did use this with Roger, who was our example of our TBI.
And he was successfully discharged to home after he was finished up in rehabilitation. So and in Roger's case, it's, we're focused really on the acute, that first 72 hours, the discharge to rehabilitation, and the discharge to home. And he'll continue with outpatient therapy and things like that. But with the case of the TBI, that's kind of more of the focus. And I think next we're going to get a little bit into spinal cord injury, and the focus shifts from the acute. There is still an acute focus, but it's really more about the long-term life planning in these type of injuries.
Thanks. And so for purposes of our presentation, that's why we wanted to identify another case study. And I'll speak about Belinda. She's our second case story, and she helps us, as Nolan indicated, understand more about spinal cord injury with independence, accessibility, long-term life planning. So sweet Belinda, and this picture, of course, doesn't necessarily denote her injury, but she was on her way to a work event and was involved in a motor vehicle accident and sustained a spinal cord injury. She's 29 years old, elementary school teacher. Her early concerns, as with many of our spinal cord injuries, are how will I return to function? That loss of physical self is very overwhelming. And families then say, well, what kind of life can I help support her to have? So at this point in our presentation, I think the story shifts from the crisis management, or the TBI presentation, to helping injured workers and ultimately non-injured workers, if we get into the concierge setting, helping them envision a future. What is their future going to look like now?
Absolutely.
So we'll continue.
And just like with Roger, with Belinda, we want to understand spinal cord injury from a holistic perspective. So just kind of a brief overview. Much like TBIs, it happens in a second. Belinda didn't wake up thinking, I'm going to be in a car accident today and have a spinal cord injury. And it does change the trajectory of her life. So that adaptation to the injury is going to have to occur over a lifetime. So when we're talking about spinal cord injuries, there's usually two kind of broad classifications. It's either going to be a complete injury where you have no motor or sensory function below that level. It's a complete separation of the spinal cord, or the highway, sometimes it's referred to, from the brain to the rest of the body. Or you have an incomplete injury where you may have a partial preservation of function. So you may have sensation, you may have some motor function below the level of the injury. In this classification, it can help determine kind of functional prognosis. What can we expect from rehabilitation? How do we now plan for rehabilitation? And it's going to change the story about how we're going to best build.
Depending on their injury level. Okay.
Exactly.
And type. Okay.
So then jumping right into those functional expectations, even if it's the same level, the same completeness, it varies by individual.
Oh, it sure does.
It's none of them are the same. You have a C6, C7, you do have potential for some upper extremity function in Belinda's case. Maybe in her shoulders, So that may affect her wheelchair mobility. She will likely need a power wheelchair because she won't be able to
Mm-hmm.
use a manual wheelchair. And even though she may be able to use a power wheelchair, so she'll have some level of independence in her activities of daily life, and it will be very achievable, but will change our kind of functional goals based on the level and the completeness of the injury. And then just for your general reference, we have the Asia Impairment Scale. This is just a global metric that providers can use to guide prognosis. Basically, it's a way for providers to communicate with one another. So you have the Asia A, which is complete no motor or sensory function, and they tested at the sacral segments as S4 and S5, so at the very bottom of the spinal cord. And then you have Asia B through D, which is the incomplete, like in Belinda's case,
Yeah, that varies.
at various levels. And then AISE is just normal level. Motor and sensory function is fully intact.
What I was going to say is I find it interesting in rehab and very heartening that an injured worker or a patient can come into rehab with one Asia identification, and based on their return of function and gains of strength, et cetera, they can leave a little bit higher, a little bit better.
Especially in that middle section.
Yes, thank you for showing us that overview. And for Belinda, and for the purposes of our presentation, the discharge, we always say begins at admission, but it's never the finish line for a spinal cord injury. It's really just the starting line. They're getting their whole rehab plan translated to how it works in her actual home and her actual community and the life that she wants to rebuild. And I smile because Belinda, again, is such a sweet woman. And as case managers, you know the domains: home access, DME. Are the caregivers trained? Is there a backup plan? The point that I'm trying to make is each one of these issues doesn't get solved on discharge day. We're going to translate medically ready into real life ready, and just trying to get a hold of an idea of what's going to surface, what's going to be a barrier, and getting the right people to the table to help fix that for Belinda. One thing that's not reflected on this slide that I did want to say is the payer, if it's work comp and in catastrophic spinal cord injury, will become one of the most expensive claims that they've had. So we've talked about that on a previous slide. A lot of these costs are reoccurring: new equipment that's needed, home modifications, which I know we're going to touch on, and then caregiving. It all cycles over again and again. Work comp will be the payer for that while the claim is open. But as we said, many of these claims will come to settlement, and then it might move into a traditional payment, maybe the concierge piece that we're going to talk about. Mm-hmm. But all in all, for a young person building a life, it has to have quality of life, and we need to know who's going to cover that money piece.
Yeah, money piece is important, especially because in Belinda's case, it's not just about the acute injury; it's for her lifetime. So figuring out who's going to be funding that and who's going to be paying for the medical necessity is really key, especially with spinal cord injuries.
Thank you, Nolan.
And also really key with spinal cord injuries is pairing DME and home modifications to create the best possible environment for Belinda for her independence. So if we don't have the right equipment, if she doesn't have a powered wheelchair and she has a manual wheelchair, she can't use it.
Or if the power wheelchair doesn't fit her right, or whatever it is.
Exactly.
Right.
So making sure, in terms of on the left side here, the durable medical equipment, we're matching the right equipment to the injury. So you're thinking things like wheelchairs, like we just mentioned, or hospital beds, pressure relief mattresses, so that can promote skin integrity. We're not getting bed sores, which can just be like insidious.
Yes.
Cycle out of control very, very quickly. If she does have caretakers in the home, we're talking things like transfer equipment. We may have mentioned the tub transfer bench for another individual, and making sure that the caregivers are able to safely assist and handle Belinda is really key here as well. And then communication and adaptive devices. We're in the 21st century.
There's smart tech.
Exactly. We have smart tech. We have access to these adaptive devices. Maybe she's able to use some kind of like Alexa system in her home to close her blinds or to set different timers and things. So finding the right DME that can pair the best with Belinda's injury is great, but also we need to bring in the home mods to support the use of that DME.
And I'll speak to that. But while you were talking, I wanted to say how blessed I feel that we work with centers of excellence with so many of our catastrophically injured patients and our spinal cord injury patients, injured workers. And they are very versed on the latest and the greatest and matching the appropriate equipment to the function. So we're really lucky that we have that. But like you said, I mean, all the equipment in the world doesn't work if the power chair can't fit through the bathroom door.
Sure.
So we work with home modification vendors, getting that right setup to help prevent the wrong outcome. Ramp construction, threshold leveling. You can't just have your brother-in-law build you a ramp to get into your house. And I know you've had an injured worker who didn't realize he had a step.
Oh yes, yeah. I had an injured worker, and because you go in and you interview the family, and you speak with the injured worker.
Yeah.
You say, hey, like, do you have any steps in your home? Is it a one-story home? Do you own your home? Because if we're going to be doing modifications, it'd be good if you own it. And they said, no, yeah, no steps.
No steps.
Nothing to get in. Should be just fine to just be able to wheel right in. And then, lo and behold, get a phone call. Oh, there's 2 steps up into the home, and we're not able to wheel me.
I mean, we laugh, but it was an issue.
It is, yeah. So it's like things that you don't even really think about. So that's why it's also really key to have an OT. In an ideal world, have an OT go out and actually perform
Put eyes on
site, and determine what exactly will be needed. And then I think you also maybe had one in the past where they didn't realize that they could even have doorway widening, so they were transferring from their chair to use the restroom every single time they need to use the restroom.
Yes.
So,
and when you find that out after the fact, it's a little bit heartbreaking. But we fix it. We put that hat on and we take care of it. So the roll-in shower, sometimes grab bars, door widening. I think we talked about most of this on the slide, but there was even a time when the home could not be modified enough. So I had an injured worker get a new home. Yes. So that was big. None of this is free. None of this is just automatically happening. Case managers, we're working with the teams to help this happen, but it has to be funded and it has to be approved. And that depends on the payer model, which we're going to talk a little bit on the next slide, to kind of help bring things.
Yeah, and we're gonna put this back into the perspective of Belinda, because she was a work comp injury at the get-go. If you haven't just, it may be just like a hiking accident or some other kind of accident where you had a spinal cord injury, you're not really in the realm of work comp. So it's this transition that occurs specifically with work comp injuries that we wanted to kind of shed a light on. So in the work comp world, we're talking about things like compensability and causation. The injury was linked to work. She was on her way to a work event.
Right.
When she was
in
a car accident.
And people do ask about that sometimes. They're like, how can it be work related if it was in a car accident?
Well, she wouldn't be going there to that event if she wasn't.
Exactly. But I do get that question. Anyway.
And we're also focused on medical necessity. So is the treatment that she's receiving, is it medically necessary? Is it clinically justified? And it has to be payer approved. So we are in constant contact with the claims examiners, making sure they understand that this is what the physician's ordered. Here's their clinical justification. Let's go ahead and get it approved and paid for. So then we can move Belinda forward the best way that we can. Also, we mentioned earlier, our main focus in workers' comp is return to work. We want them to return to the highest level of functioning that we can so they can return to gainful employment. So, maybe that's retraining. Maybe they're going to be retrained to do different
In some
jobs.
states, they do have vocational retraining.
Exactly. Maybe it's, they're doing part-time and they're doing some form of wage replacement benefits. So return to work is the goal in workers' comp, which is is different from traditional insurance, which we'll get over to in a second. And always doing cost containment. We're always trying to contain costs while still maintaining the highest level of care that we can.
Thank you.
And then in Belinda's case, she will have a settlement. And then at that point, the workers' compensation on the left here will close down. And the work comp case manager, which is us, their role will also close down at that point. But that's when it kind of transfers over to concierge care.
Because there are times when a family will reach out to us and ask, due to our concierge leg, if we can handle management of a catastrophically injured patient who is no longer an injured worker. And we have had clients and accepting of those.
Absolutely, yeah. So at that point, we're moving away from the work comp world, and then we're helping them navigate things like coverage limits and prior authorizations. Maybe there are work comp providers not in their traditional insurance network, and we have to set them up with a new provider or new, therapist.
Yeah.
And we're really focused here more on quality of life as opposed to just return to work. Like, what level of independence can we get to? How quality, what kind of quality of life can Belinda have? And then also, like, at the center of both of these, really, but is patient advocacy. So we're going to be an advocate on behalf of the injured party at this point, no longer
Yes.
the injured worker. So it's still the same patient, and they still have the same clinical needs, but who's paying for it differs, and then also the kind of the service model from a case management perspective differs. In concierge care, we're doing very, very similar things as we would in the work comp space. We're advocating for them.
Mhm.
We're helping them navigate the different insurance aspects. We're coordinating care, and it just really varies on who's funding that. It can be paid for privately by the family or
Right.
from a variety of other funding
It just
sources.
depends. But we're doing all of these action verbs. It's the same injured person, same clinical need, just a different payer source.
Exactly.
And this is a little bit repetitive of what Nolan was saying, but focusing on the middle placard, regardless of the payer, regardless of who's funding it, the middle placard is the shared goal, a meaningful recovery for Belinda. It is a really specific language, work comp. You said causation and compensability. It's a language focusing on return to work and quality of life, whereas private pay, the work is kind of taken out of the equation. But the shared goal is still the same: maximize her function, safety, dignity, independence, help her have a meaningful return to her community. And yes, the funding can change, but the next question would be, who keeps this plan connected across the settings?
It can be the same person if you're going from work comp to concierge care, or it can be different. It can be different groups as well.
Mm-hmm. Mm-hmm. When we shared earlier the numbers, the exciting numbers,
Turn to the numbers.
We wanted to back it up with this slide, and just that solid statement on top: coordination is not just an administrative task, it's a clinical intervention. So this is where we prove that this coordinated care is not just supportive, it actually moves the numbers. The 14%, a 2023 meta-analysis found that patient family-centered transition interventions, if the family was involved and the injured worker was involved and they knew everything that was happening, their readmission rate risk was lowered. And that's exciting. That's the work we do every day. So the 21%, a 2024 review tied that if you confirm that a patient's follow-up appointments are set and they get that follow-up care, they had fewer readmissions in the first 30 days. 21% fewer readmissions. Wow.
And again, it's beyond just clerical. You got to confirm and make sure they have a transport to those appointments.
Yes, all of those pieces that we talked about shows up. Why is that important? Because they were 21% less likely to get readmitted to the hospital. And for spinal cord injuries, about 55% are rehospitalized in year one. For sure. And that does drop to 38% in later years, but most of those drivers for rehospitalization are preventable. Early identification of UTIs, watching that skin integrity, making sure the equipment is not failing and is being cared for properly. Mm-hmm. Knowing when a caregiver is experiencing burnout.
Yeah, recognizing.
So that they just don't drop out and leave the injured worker high and dry. So these home assessments, ongoing family training are clinical care, not just extras. This was the 32-75% that Nolan alluded to earlier. And yes, it was specific from a Paradigm Milliman supported study, but still, the vendor data is a small subset, but its direction still points to everything else. 32% lifetime cost savings when you have catastrophic care management at the ready. And then 75% return to work.
In managed cases.
So coordination lands in a positive place because we change the risk profile. Good coordination keeps a CAT case from becoming more catastrophic. I should have that on a t-shirt.
Make a t-shirt.
Let's just
We're turning to Roger and
we
Belinda.
are.
Mhm.
We are. We're revisiting our injured workers years later, just to kind of give you some context. Roger, who we focused on for the TBI and the critical care and understanding transitions and where handoffs fail, um, he actually had a pretty good outcome. And I know it says on here, but this is from Roger. He walks his kids to the bus every morning, and he's so happy to do so. He still experiences those cognitive challenges Nolan talked about on his slides of understanding TBI. He didn't return to project management in a construction site, but he did return to meaningful activities. He participates in his community. So all in all, very well. And then Belinda, she struggled at first. She was challenged by the loss of her physical function, but over time,
her identity a little bit as well, you know.
She's 29. Yeah, it was really
big
hard
shift.
But she was able to return to her professional life as a teacher. She does use those adaptive tech that you talked about. Okay. She uses them very well, and she's living her life. It looked different than it was before, but as it says on here, she built a new one. So, at the risk of sounding a bit corny, as a case manager, success means we're helping walk alongside a person on what is the most difficult journey of their life as case managers. And success looks like this: we create a meaningful future in spite of their injury.
A good outcome.
Would you have anything to add to that?
Not to Roger and Belinda. I'm glad they're both doing well. But I think we can just maybe hop into our key takeaways and kind of run through.
Let's do it.
Just our presentation. You know, at the very start, we were talking about our learning objectives, where we want to differentiate, identify, and apply. Hopefully, going through Roger and Belinda's stories, you saw different ways where we'd be able to utilize each one of those action verbs. And in case management and catastrophic care specifically, we are working to rebuild and have an outcome like in Rogers and Belinda's case, where they can return to the best level of function if they can.
Exactly.
So the catastrophic injury is not just even about the injured worker or the injured person. It ripples beyond that. So you're talking the family, the employers, we're talking about their community. Mm-hmm. Everyone's going to be impacted by the injury in some way that is close to the injured worker. And then also we talked a little bit about early intervention, early identification, early intervention, getting in quickly and to be able to direct the case to where we need it to go to make sure that we're on the right trajectory. We're getting the right clinical treatment that we need, and we're identifying things early that may be costly later on if they hadn't been caught. That's where it's key to have early intervention. Mm-hmm. And as getting in early is just really good for case management. That. And then communication, we talked about it with Roger. Things sometimes fall through the gaps, identifying the right players that are involved in the care coordination.
We gave them a toolkit.
We did. We gave them a toolkit. That's preventing readmission. Yeah. And that communication, it's going to just prevent complications. And if it wasn't documented,
it didn't do it.
It didn't happen.
So. And we document our collaboration with number 4. The collaboration also reduces readmissions because the internal team and the external team are just one team. There's no I in team. So glad I got to say that. Great case management. It protects everybody. That shared protection. I picture an umbrella. It protects the injured worker. It protects the families, the employers, the payers. You do it well, and you create extraordinary outcomes. We can do extraordinary things.
Absolutely.
So I think this would be the place that we would just say what an honor and a privilege it is to work with these type of injured workers. And we wanted to be able to share this with you today. So we thank you for your attention and for joining us. Yes. I would say that people may not remember every intervention that you do as a case manager,
sure,
but they remember you and how you supported them throughout this journey.
Very difficult time.
So this is where we will pause. We will
Pop
see
up
if we have
references.
Oh, yes. Wanted you to be sure and have a reference slide when we talked about those numbers that I'm so excited about.
We can do a little bit more digging on them. Some interesting data for sure.
And they'll have this. They'll have a copy of this.
Good.
And this is our connection slide. I understand that we might be running long and may not have time for questions and answers now, but we wanted to be sure and give you our contact information so that you can reach out. We can follow up by email. We're on LinkedIn. All the socials, I guess the young kids are saying. And of course, my email or Nolan's email. Please feel free to reach out.
Reach out to us. We also have, as Patricia mentioned earlier, we do have a podcast where we talk about all things work comp with many different types of people that are in different players, internal case managers, people that work in rehabilitation facilities. So it's cool to hear all the different perspectives, even in this what people consider niche field, but as we've seen is quite extensive.
So. Yes. So thank you all. Thank you all.